And okay, go ahead, Dr. Gill.
Sure. Great. Thanks, Rachel. I'm so sorry. I was really looking forward to Catherine Moore's presentation today, too. And so I'm sorry for the last minute switch. And this was something that I just had on the ready. So hopefully people are okay with talking about perinatal substance use today and really pharmacotherapies for a few conditions. I just wanted to start out by just reminding folks that all of our diseases live in a context across the board in medicine. And it's really important in taking care of individuals with perinatal substance use that you are aware of that context. Because there's a lot of factors that are going to be at play and how that is affecting that person's treatment and their condition and their outcomes. And so all of these conditions, poverty, lower education status, poor health, high-risk behaviors, violence, trauma, legal issues are very common in substance use disorder populations. And it's just really important to keep those sort of in mind as you're working through them. This doesn't happen to everybody. These are not 100% going to happen, but it's more common to have these factors at play. And so, oops, sorry. So overall, our approach to perinatal substance use disorders is keeping the mother-infant dyad and the family unit at top of mind and how that unit is working together. I think in substance use disorders in general, as people with those conditions approach our healthcare system, they're often not met with a lot of kindness, respect, or compassion. And that holds even more true, I think, when individuals become pregnant. There's just an added layer of judgment that happens. And so meeting this group with kindness, respect, and compassion is really the approach that you want to take. And you would be really amazed at the response that you get when you do that. Our goal is really to give voice and choice to these individuals because there's often something that's taken away from them. And they are going to be a much better partner in your treatment when they feel empowered to actually voice what it is that they want to be doing for their treatment. So all of our approaches really try to be patient-centered and use shared decision-making, and we'll talk about that really as we address pharmacotherapy for this population. We also have to be addressing any social or structural determinants of health, knowing that if we're not, a lot of those things are going to impede somebody's recovery and continued recovery and staying well. Really common for individuals to have comorbid trauma or mental health conditions. And so we have to keep an eye on those and make sure that those are being addressed if we want to make improvements in perinatal substance use disorders. As much as possible, we want to integrate care within prenatal care, so that all team members are sort of looking at the same issues and working together to optimize treatment. And as soon as someone comes into pregnancy with a substance use disorder, we should already, for a lot of our patients, already be talking about postpartum contraception. As you all know, half of our pregnancies are unplanned. Among a perinatal substance use disorder population, it's about 80%. So just sort of keeping that on the to-do list as we work together throughout pregnancy and postpartum. So you guys are all very familiar with these changes that occur during pregnancy and how the body sort of affects medications, and really with absorption being the only one that could maybe slightly increase drug levels, but really mostly due to the distribution, metabolism, and elimination changes that happen in pregnancy. Most of the time our drug levels are going to decrease, and we often don't measure drug levels, but we're often just giving people a heads up that, hey, this dose might be working for you right now, but let's keep checking in on your symptoms and how you're doing, because we might need to make some adjustments, more than likely going to need to make some adjustments as we move along pregnancy. And that's just really important because oftentimes people will take a medication and they're so excited that it actually works for the first time. And then all of a sudden it stops working. And if you don't give them a heads up about that, they can often just stop the medication or just experience a lot of distress until you sort of work out this issue. So I just wanted to start with what I wanted to cover today were really just the most common drugs that are used in pregnancy, which are tobacco and alcohol. And then we'll get into some of the illicit substances. And as you can see, so this is our National Survey on Drug Use and Health, looking at past substance use, past month for pregnant individuals. And tobacco products is trending down. That's really wonderful to see. Alcohol is sort of holding strong around 10%. Among our illicit drugs, the prevalence of that seems to be creeping back up, and that's primarily driven by cannabis use. And so we'll talk about that. I believe that in maybe a month or two, we'll be talking specifically about opioids and opioid use disorders. So I'll reserve that for a later time, and really just focus on tobacco, alcohol, and cannabis for today. What's also important to recognize that although we're doing a lot of counseling about these substances and pregnancy, it's really common for people to be using multiple substances at the same time. So we don't really do studies on multiple substances. So it's hard to just talk about the impact of these as a group. And we often talk about them individually, but really it's more common for them to be used simultaneously. As we know, the prevalence of substance use really does decrease as people go across pregnancy, but following pregnancy is really when we have a very high rate of return to substance use. It's about 80% within the first few months after delivery. And so that's a really high risk time. And what we're trying to do is prevent return to substance use in the postpartum period. And that's also where we have our highest rates of maternal morbidity and mortality. So oftentimes individuals that have substance use disorders and coming into pregnancy, we often don't see them until pretty late in pregnancy. There's delays in prenatal care, delays in treatment. That can be because there was a lack of knowledge about the pregnancy. Oftentimes there is a huge fear of being separated from the baby as a result of a Department of Social Services case being opened, or legal consequences, or just the judgment that they experience as they come into our healthcare systems. There's also a number of social factors that get in the way in terms of getting care, such as transportation, childcare, getting insurance. Although Medicaid is an essential benefit, most people don't always know that. And it's really when they get into care that they realize, okay, yes, I do have insurance. And also just a lack of understanding of what treatment could look like in substance use disorder care. Maybe they've had some prior not great experiences. And so really sort of reintroducing that in a different way sometimes can be really helpful when folks get to care. Our general approach, especially with prescribing medications for perinatal substance use disorders, is always this, what we call a risk analysis. And I know Dr. Claire Smith spoke last week about a lot of these approaches. So I'm just going to sort of highlight them again and how we address medication use in pregnancy. So essentially, we're weighing what we know about the risks of the medications and the unknown risks, but we're weighing that against the risk of the untreated illness. And really providing that information to individuals so that they understand that information and that they can make an informed decision about whether they want to use a medication or not, that's really in line with their preferences and values. It's really common for individuals to say, oh, I want that medication because I know that's best for baby. And I understand that, but what's really best for baby is what's best for mom. If that medication is not going to work for mom, then it's not really best for baby. If that medication is going to hold that person and they're going to do well and they're not going to relapse to substance use, that is the best medication. And so we often just make sure we're prioritizing women's health. When we continue medications, oftentimes if someone is on a medication, they become pregnant, sometimes they just stop it or they try to lower the dose. And we don't want to do that until we sort of have an assessment of what's going on. Because oftentimes if you stop a medication and you relapse, you're sort of getting, the exposure of relapse and then restarting the medication and exposure of the drug again. Or if you're not using a therapeutic dose, you're just getting the risk of the medication without benefit and risk of potential relapse. So we really try to make sure that if we're going to use a medication, we get to a therapeutic level and continue to check on that throughout pregnancy. It's often best to use the medication that has worked best in the past, just because if we try something new, it doesn't work, we've got exposure to that drug, we've got time that we have to use to get onto a different drug, and now you've got 2 drug exposures and continued symptoms throughout. So if you have that history that this has worked really well for someone, that's probably the medication that you want to use. As much as possible, we try to minimize polypharmacy. And then also, medication is just one piece of this picture. We really want to think about what other therapies that we could add on to this, what other supports, what other resources can we make available to sort of decrease stress in individuals' lives and provide some evidence-based tools for managing substance use disorders and prevention of relapse. And again, planning for postpartum contraception. All right, so treatment of tobacco use disorders in pregnancy. So up on top, I listed the interventions, the behavioral interventions that have been best studied and have shown the most efficacy, which include motivational interviewing and contingency management. Contingency management is highly effective, but very difficult to put into practice, especially because it often includes financial incentives. Motivational interviewing is always a great approach, really identifying for that person why it is that they would want to engage in treatment or stop using substances. But in addition to those behavioral interventions, we're also going to talk about what medications are available. So for tobacco use disorders, we've got 3 agents. We have nicotine replacement therapy, we have varenicline, and we have bupropion. And so I'll talk about each of those individually in the context of pregnancy. And then essentially we're weighing the risks of those treatments against the risks of untreated tobacco use disorders for mom, for newborn, and for developing child. So here's what we know about risks of tobacco use in pregnancy and postpartum. And one of the reasons I wanted to sort of focus on the legal substances is that oftentimes people think, well, it's an illegal substance, and so that's got to be much, much worse. This is legal, so this can't be too bad, and it's natural, it's grown. But what we can tell individuals is actually tobacco and alcohol are some of the most harmful agents that you can use during pregnancy. And we've got a lot of data for a long time that have been showing these sort of effects and outcomes. And so we often talk about sort of what are the risks of tobacco use in pregnancy. One thing that I'll mention is that a lot of individuals that use tobacco prior to pregnancy, as soon as they get pregnant, they'll stop. Like half of people will discontinue their use of tobacco, which is really impressive. But what then you're left with is the folks that have that intervention hasn't helped for them. So it's almost like they have not done well with a first line intervention. And then you're left with a group that is sort of selected out to be more difficult to treat. And so that will make sense as we talk about some of the agents to treat that. But again, so just again, reiterating with folks that tobacco is not a benign thing to use in pregnancy. These are the risks associated with this. If people do stop using in pregnancy, we want to then focus on preventing that return to use in the postpartum period. So this is what we know about risk for treatment of tobacco in pregnancy. This is looking at nicotine replacement therapy, or NRT. We actually have 8 randomized control trials looking at NRT for smoking cessation in pregnant populations, which is pretty impressive. There's not a lot of RCTs in peripartum populations. But what we can tell you here is that there's not a whole lot of increased risk for things like prematurity, miscarriage, preterm birth, neonatal death, C-section, congenital anomalies, and NICU admission. So that's very reassuring. But there's also some unknown risks of treatment with NRT that have not been. Some of these have been animal studies. Some of these are, one human study. So again, we're taking that with sort of a grain of salt, but we don't truly know if these are risks or not. So what we typically do, if this is a medication that's worked really well for someone in the past, we talk about, what's the risks of continued smoking for you? What's the risk of this medication? And what sort of makes the most sense for you? And if we're going to go with NRT, we really have to make sure that we are planning a time to stop smoking, because we don't want them to continue to smoke and be on NRT at the same time. So this is sort of that risk conversation that I talked about. Here are the risks of treatment. Here are the risks of continuing smoking. What is it that you want to do here? And as you can see over on the left, those randomized control trials that I mentioned really did not show this incredible effective benefit of NRT for smoking cessation and pregnancy. And we looking at that data, I think a lot of that has to do with, again, you're selecting out for a population of people that have really difficult tobacco use disorders to treat, right? They've sort of failed the first line treatments. They've actually ended up in a randomized control trial. So this was a pretty a select group of people. There was also some concerns about dosing of NRT in these studies, and people, if they did return to smoking, they were stopping NRT. So the effectiveness for this based on these studies is not great. So what we typically do is really look for the patient that's had a good response to NRT in the past. That is sort of the ideal patient to use NRT with in pregnancy, and that they really only need a short course. We have a plan for cessation, and they really understand the risks of this drug and the risks of smoking, and they're going to stop the NRT if they resume smoking. Some people recommend removing the patch at night, as long as that doesn't mean they wake up in the morning with intense cravings, but removing the patch at night is one way to sort of decrease the exposure, but again, not at the risk of it being subtherapeutic if that's the case for your patient. So varenicline, this is not a medication that we use for pregnant individuals for smoking cessation. We have no RCTs. We don't even have retrospective studies or prospective controlled studies. There's no data in lactation. The recommendation is really not to use this in pregnancy or lactation. There's not a lot of people on this medication, and the treatment response in general is not fantastic. Bupropion, though, Wellbutrin, this is a medication that we don't have RCTs on. We don't have a cohort study for pregnancy for nicotine. Sorry, I put my phone away. It keeps buzzing. For tobacco use disorder in general, but we do have a lot of data on bupropion for depression and other issues. So what we know about the risks of treatment with bupropion is that we're not concerned about fetal anomalies or stillbirth or low birth weight or preterm birth or neonatal death. We don't have a lot of data on long-term effects, so that might be of concern, but then we know that there are continued risks of smoking. So again, doing that sort of risk conversation with people to see what makes the best sense for them. So that in summary, I think if I had to say, the perfect person for Wellbutrin or bupropion, obviously if they had been on in the past and it was effective for quitting smoking, obviously if it's somebody who had tobacco use and they wanted to cut down and they also had symptoms of depression or had a depressive episode, this would be your ideal medication, because you can kind of use one medication for two indications. Which is really nice when that happens. So that's who I would sort of think about this medication for. All right, so moving into alcohol use disorder, just want to look at the time. For behavioral interventions, the interventions that have sort of the most efficacy are the same as for tobacco: motivational interviewing and contingency management. If someone is in alcohol withdrawal, we're obviously going to use benzodiazepines. And then we have our FDA-approved medications for the treatment of alcohol use disorder, which are camprosate, naltrexone, and disulfiram. And we're essentially weighing the risks of those medications against the risks of untreated alcohol use disorder for mom, baby, and developing child.
And Dr. Gill, you are fine on time, so
Okay.
No need to rush.
Okay, sounds good. So in terms of risk of alcohol use in pregnancy, and I think I saw Michelle Cunningham on, she has done a lot of work to try to reduce alcohol use in pregnancy. We know this is the leading preventable cause of birth defects and developmental disabilities. It has a huge impact on obstetric health and newborn health, particularly fetal alcohol syndrome. And so we often talk with individuals just about all of these risks from an obstetric perspective and for the newborn. I would say, more recently, the field of psychiatry has taken up FAS and come up with this other name for the disorder, which you call neurobehavioral disorders associated with perinatal alcohol exposure. And that is really to capture the cognitive, the neurocognitive, the regulation and adaptive functioning that gets affected by alcohol use, by maternal alcohol use on the developing infant. A lot of times people get caught up in FAS around having the facial anomalies, which is actually not the most common. And I think what psychiatry is trying to do is really talk about the impact of alcohol use in pregnancy on the developing brain and how this affects regulation, neurocognition, and adaptive functioning. And obviously, when you're talking with a patient, talking with them in those terms is not helpful at all. And so I think actually a more helpful way to talk about alcohol use in pregnancy is, how does this show up in real life? And so oftentimes what we talk about in terms of like self-regulation and neurocognitive challenges really just shows up as problems at school. These kids end up getting suspended, they get expelled due to disobedience and truancy. They often have a lot of legal problems. They end up in the criminal justice system just because, again, that self-regulation, anger, frustration. They often get taken advantage of by other people because they don't always understand other people's motives. And so they're really susceptible to persuasion and manipulation. About a third of individuals that have FAS or are often at risk for developing substance use disorders, being unemployed as they're older, and having other mental health problems. So I think when you talk with patients from the perspective of these of alcohol in pregnancy use and these outcomes, it's just much more powerful, much more easily to be understood, and really gives someone a sense of how that drug is affecting the developing brain of a fetus. So there have been so many behavioral interventions targeting alcohol use disorder in pregnancy, just because we know of the significant morbidity associated with that. And these are all the ones that have been tested. None of them really come out as like, hey, this is the best one. I would typically try to pick the one that is that patient is most motivated to engage in, or sort of makes the most sense given everything else that's going on in their life. So here are 3 medications that we get to use for the treatment of alcohol use disorder: naltrexone, disulfiram, and elcamprisate. We have no efficacy studies of these medications in pregnancy, and we essentially don't have, so I really can't talk a lot about the risks for alcohol use disorder in pregnancy. We can talk about it for opioid use disorder for naltrexone, and we'll do that in a second. But the one that we typically do not use is disulfiram, just because of possible malformations and sort of that reaction that can occur, the disulfiram alcohol reaction that can occur. And also we don't use acamprosate because it's just a total unknown. So if we are going to use one of these medications, it's typically naltrexone, because we have some data from within opioid use disorder. And I think that's on the next slide that I can share with you. Yes. Okay. So again, no efficacy studies using naltrexone for alcohol use disorder in pregnancy, but we do have some good cohort studies for opioid use disorder. And there's essentially some studies where we're comparing methadone versus buprenorphine versus naltrexone. And one very small study showed that there might be some increased risk of urogenital defects that hasn't been replicated, or potentially a risk of ectopic pregnancy. Again, that hasn't been replicated, but it's just been shown in the literature. And obviously at much lower rates of NOWS or NAS, as you would expect if someone had an opioid use disorder. We typically do not use this during pregnancy, but if there is a really clear history of somebody having benefit from this drug in the past, or they really cannot curb their drinking in pregnancy, we might give this drug a trial, giving that we know of all the negative outcomes that can occur from alcohol use, and naltrexone looks a lot less risky. So from that perspective, we might give this medication a try. So lastly, I was going to talk about marijuana use in pregnancy. And as I just showed you earlier, this is sort of blowing up that earlier graph, just looking specifically at cannabis use or marijuana use in the past month. As you can see, these numbers are trending up, which is not so surprising across the country, given that there's greater legalization of use in states, and also medicinal use as well. Let's see, I'm not sure why that's in there twice. Okay, so what gets really interesting about this area is, where is it that you're practicing in terms of how you address cannabis use during pregnancy, because you might be in a state that has laws around cannabis use, but may have different laws around substance affected infants. And it's really those 2 pieces of information coming together to understand how to manage this during pregnancy in the postpartum period. I think probably what's the most important thing to ask patients is why they're using cannabis. And the most common reasons for that are typically anxiety, sleep, pain, stress, nausea, and vomiting. And so if you can sort of uncover what is the benefit that someone is getting from cannabis, and why are they using it? What is the what are the good things for this? Like, how is it helping them? And if we can figure out a different way to address that issue, that is probably the most likely way that you're going to be able to get someone to cut down using cannabis in pregnancy. So what's important about cannabis in pregnancy and breastfeeding, here are just some pharmacokinetic profiles. We know that it is readily crossing the placenta. It's highly lipophilic. It's being distributed in fetal brain and fat. We have cannabinoid receptors found as early as 14 weeks gestation, and the expression of that really does fluctuate throughout gestation. And we know that infant plasma levels are roughly 10% of maternal levels. So baby is seeing a relatively large amount of this if mom is smoking in pregnancy or using or eating any sort of cannabis in pregnancy. Breastfeeding cannabinoids accumulate in the breast milk because it's lipophilic and fatty. We have good information about that THC dose continuing to be in the breast milk, even if some people are taking a little bit of time in between using cannabis. We don't recommend breastfeeding, or when someone is using cannabis regularly, and we recommend significantly cutting down as much as possible and stopping if they are going to breastfeed while using cannabis. Okay, so treatment of cannabis use disorder in pregnancy. Unfortunately, we don't have any medications available to us. I think that the medical approach is really just understanding the symptoms that they're having and why they're using cannabis, and seeing if you can use other agents or behavioral interventions to address those issues. And again, we are just, looking at that sort of the risks of those management of symptoms and therapy against the risks of cannabis exposure in pregnancy. So this is sort of what we know about the obstetric risks and the newborn risks of cannabis use in pregnancy. So we've seen reduced fetal growth, low birth weight, which is possibly dose dependent. We see small for gestational age, placental abruption, increased NICU admissions. Those have been the ones that have sort of borne out most consistently in the literature. For kids and their development, what we're seeing is increased cognitive deficits, particularly in executive functioning. We see increased behavioral problems, hyperactivity and impulsivity, and increased risk of mental health problems, particularly depression, substance use, and psychosis. Where a lot of this data came from is actually from these two very large prospective studies that really followed children very closely throughout up to 21, 22 years old. And a lot of this is really demonstrating a lot of the executive functioning that we're seeing in these kids that were exposed in utero to cannabis. And so you can see, or even follow some of those studies now as those continue. That was actually all I had put together. So I'm going to go ahead and stop sharing. And happy to open it up for questions and discussion.